Okay, let's get started then. Good morning. Welcome to the 8th and final meeting of the Legislative Committee on Healthcare for the 2019-2020 interim. Thanks to everyone who is joining us online and throughout the interim. We appreciate your participation. Members, please remember to mute your microphone when you are not speaking. Our committee policy analyst is going to call roll. Ms. Kamlasi, please go ahead.
Senator Hardy.
Here.
Senator Ratty. Here. Senator Woodhouse. Here. Assemblywoman Monk.
Here.
Assemblywoman Titus.
Here.
Assemblywoman Cohen.
I am here. Okay, so we're all present. Some housekeeping items before we begin. Meeting materials, including the work session document, can be accessed on the committee's webpage. Anyone who would like to receive electronic notification of an access to the committee's agendas, minutes, or final report can sign up on the Nevada Legislature's website. We're going to have 2 periods of public comment, one at the beginning of the meeting, one at the end of the meeting. Public comment is limited to 2 minutes per speaker. There are 4 ways to provide public comment, all of which are listed on the agenda, and these include calling. The phone number is area code 669-900-6833. So that's 669-900-6833. And then entering the meeting ID number 965-0852-2608 hashtag. So 965-0852-2608 hashtag. Emailing comments to healthcare@lcb.state.nv.us. So all one word, healthcare@lcb.state.nv.us. Mailing comments to the Research Division at 401 South Carson Street, Carson City, Nevada, 89701. That's 401 South Carson Street, Carson City, Nevada, 89701. Or faxing comments to area code 775-684-6600. That's area code 775-684-6600. This meeting will be recorded and available on the legislature's website as well. So as an overview, our agenda includes a report regarding the committee to conduct an interim study concerning the cost of prescription drugs and our work session. But first, we're going to open up to public comment. So we'll move to agenda item 2 to do that. Once again, public comment is 2 minutes to ensure everyone is given a fair opportunity to speak. We also encourage members of the public to submit written testimony through one of the methods listed on the agenda. All callers should state and spell their name clearly for the record. LCB's Broadcast Production Service, or BPS staff, are coordinating the public comment telephone line. BPS staff, please add the first caller to the meeting.
Good morning. Thank you, Madam Chair. And we will begin with the caller with the last 3 digits of 029. Please slowly state and spell your name for the record. You have 2 minutes to speak and may now begin.
Hello, this is Annette Lincicome. ANNETTELINCICOME. Can you hear me?
Go ahead, caller.
Hello, Thank you, committee members, for your dedication to overall health in our state. My name is Annette Lincecum, and I'm speaking to agenda item number 5F on behalf of the Nevada Dental Hygienists Association, the only organization in Nevada that represents the nearly 2,000 licensed dental hygienists and the newly adopted mid-level provider dental therapists. We would like to go on record showing support for the BDR for oral health and would love to see it move out of this committee with a few recommendations, which we've discussed with Dr. Capurro. We would like to publicly thank Dr. Capurro for her collaborative effort. She's been phenomenal to work with. The most important recommendation that we'd like to make is regarding the statute 629.031. We would like to propose to add the dental hygienists and dental therapists as recognized healthcare providers. In 2018, the U.S. Department of Labor changed the standard occupational classification for dental hygienists to 29-1000, a treating or diagnosing practitioner, the same as dentists. We would appreciate the committee to consider adding language that accurately represents these two very important professions, bringing Nevada statute up to date. Also, Section A3, page 9, teledentistry definition. Only 2 of the possible 4 pathways of teledentistry are listed in the definition. We recommend also including mobile dentistry and remote patient monitoring. Section A5, page 9, dental home definition. The proposed definition of dental home is limited to children. Many entities like the American Dental Hygienists Association have definitions of dental home that are not age restricted, which support the importance of dental home for all populations. And finally, Section C, Section D, page 10, mandated CE for licensure and mandated liability insurance in statute. To avoid unnecessarily bogging down proposed legislation, we suggest that continuing education and liability insurance be addressed by regulations adopted by the Nevada State Board of Dental Examiners instead, if appropriate. Statute is not the customary location for CE and liability insurance mandates. We sincerely thank you for your time, and again thank Dr. Capurro for her countless hours of work to promote oral health in Nevada. I'm happy to be available for questions.
Thank you. We will take the next caller with the last 3 digits of 900. Please slowly state and spell your name for the record. You have 2 minutes to speak and may now begin.
Good morning. This is Dan Musgrove. First name Dan, D-A-N. Last name Musgrove, M-U-S-G-R-O-V-E. Good morning, everyone. Madam Chair, members of the committee. Dan Musgrove representing the Clark County Children's Mental Health Consortium. I'm the chair of the consortium. We are a kind of a late add to the work session document. Agenda item number V1, you'll see is information from the Children's Mental Health Consortiums. And I just wanted to ask the committee, with the indulgence of the chair, and again, I appreciate the chair as well as Megan Kamalaski adding our information. Many of you might have been aware that the first meeting that was canceled due to the pandemic, March 18th, the Children's Consortiums were scheduled to be on that agenda, and we were going to present to you our 10-year strategic plans. The legislature created the consortiums back in 2001 in the AB1 special session bill, and our focus is on, obviously, children's mental health. In NRS 433B.335 requires us to do many things, and one of them is to put together our 10-year strategic plan. In the documents that you received, we tried to put together some goals and strategies, and there's 3 consortiums. There's the Rural Consortium, the Washoe Consortium, and the Clark County Consortium. All I would like the committee to consider would be to, as they have done in previous interims, is provide a letter of support that, and again, considering the budget limitations that all of you will face going into the 2021 session, that the 5 goals and 6 strategies of the Rural Consortium, the 3 goals and 8 strategies of the Washoe Consortium, and the 6 goals and 7 priorities, as well as 4 legislative asks that the Clark County Consortium put together in your documents, that the committee considers supporting our strategies, our goals of advocating on behalf of children's mental health, and that you prepare a letter in support both for the legislature and the director of HHS. And again, I thank you for the opportunity. Thank you, Madam Chair, as well as Megan's inclusion of our documents, and thank you very much.
Thank you, caller. We will take the next caller with the last three digits of 194. Please slowly state and spell your name for the record. You have 2 minutes to speak and may begin.
Tom, T-O-M, McCoy, M-C-C-O-Y, Nevada Chronic Care Collaborative. Nearly two-thirds of Nevadans have a chronic disease. The significance of chronic disease has been dramatically and tragically emphasized by its role in the risk factors and deaths associated with COVID-19. NCCC advocates so Nevadans with chronic health conditions become healthier and less costly to the healthcare system. We brought three policy issues to the committee's attention. Each address a barrier to access or result in cost to the system or the patient unnecessarily. Many Nevada chronic care patients rely on co-payment assistance programs to be able to afford their specialty medications. The health plan's accumulator adjuster program precludes any financial assistance from counting towards the patient's deductible. Under step therapy, or fail first, even though a doctor has recommended drug A for a particular patient, an insurer may require the patient to first try lower-cost drug B or C or D, only after a step series of drugs are shown to be ineffective will the patient receive the treatment their doctor determined was the most effective in the first place. Step therapy is often applied to chronic diseases, raising life-threatening or quality-of-life concerns. Prior authorization is a health insurance process that requires a provider to qualify for specific payment okay before providing the service to an insured patient. Legislation would increase transparency and improve health outcomes by offering standards for approval times, expectation of payment, and ensuring that the voice of the patient's provider is part of the process. The current lack of time standards can lead to severe adverse medical events and even hospitalization for a chronic care patient. While the committee's work session agenda fails to include these access to healthcare barriers, we're pleased to see that it does address some potential legislation that would benefit chronic care in Nevada. Thank you.
Thank you. Next caller with the last three digits of 525. Please slowly state and spell your name for the record. You have 2 minutes to speak and may now begin.
Good morning. I am Dr. Mark Funke, M-A-R-K, F-U-N-K-E. I am the President of the Nevada Dental Association. Dear Chair Cohen and Legislative Committee on Healthcare, the Nevada Dental Association supports the work session documents submitted regarding the oral health initiative encompassing teledentistry, emergency dental responders, and dental loss ratio. I would encourage this committee to not make any amendments to these work session documents and to pass it in their entirety. Dental professionals play an important role in health care, and these initiatives will increase dental care throughout the entire state of Nevada and add to the access to care for everyone. Thank you for your time and consideration.
Thank you, caller. Next caller with the last three digits of 570. Please slowly state and spell your name for the record. You have 2 minutes to speak and may now begin.
Good morning, this is Leah Cartwright from Nevada Psychiatric Association, LEACARTWRIGHT. The Nevada Psychiatric Association supports work session item B4A and B, requiring DHCSP to apply for an 1115 demonstration waiver. This waiver will increase patient access to psychiatric treatment beds across the state that are not available due to outdated federal Medicaid rules. We will submit a graphic detailing what the IMD exclusion is and why a waiver is necessary for patients with substance abuse disorder or serious mental illness. A recording of our IMD presentation at the Washoe Behavioral Health Board on August 10th is also available. We would also like to express our support for item C6D, expanding postpartum Medicaid coverage from 60 days to 12 months following childbirth. According to the CDC Erase Maternal Mortality Update for the Western District, mental health conditions are the leading cause of preventable pregnancy-related deaths. These deaths, including suicides and overdoses, were more likely to occur between 43 days and 1 year after giving birth. Extending postpartum Medicaid coverage for a full year will give mothers continuity of care and access to appropriate treatment for any number of postpartum health issues, including postpartum depression and postpartum psychosis. Babies continue on Medicaid for 1 year after birth. Continuing this coverage for the mother as well will also ensure these babies have a healthy patient too. Thank you.
Thank you. Next caller with the last 3 digits of 928. Please slowly state and spell your name for the record. You have 2 minutes to speak and may begin.
Good morning. My name is Mitch Burney, M-I-T-C-H. Last name Burney, B as in boy, E-R, N as in Nancy, E-Y. Good morning, and thank you, Madam Chair and the committee, and everybody who's attending today's meeting. I represent USARehabCenters.org. We created a user-friendly database for drug addiction, alcoholism, rehabilitation services, including mental health and legal services for those in need of criminal defense for drug and alcohol-related crimes. What we found was that if you were looking for a hotel on the beach and ocean view, king bed, non-smoking, pet-friendly, free Wi-Fi, and a continental breakfast, there were a half a dozen different websites that you could create a multi-criteria search and instantly retain those results. But in the treatment industry, there wasn't an effective resource for that, and that's what we created, a user-friendly experience for individuals to find the services, precise services that they need. What we're here today to do is to ask for the support and those members of the state legislative body, senators, assembly persons that are interested in championing our cause with us and getting the word out. We just launched this, and the most critical thing we can do in light of the COVID-19 pandemic, which has increased addiction, alcoholism, overdose deaths, and suicides, is get this populated with the providers as quickly and efficiently as possible. And for providers to list their services, it takes less than 10 minutes. It's all online and automated. And they can go to usarehabcenters.org and then click on list your facility. Again, that should take them less than 10 minutes. And if anybody needs any assistance in getting those facilities listed, they can call me directly. Again, Mitch Burney at usarehabcenters.org. And my phone number is 775-571-1928. Again, 775-571-1928, or email me at mitch@usarehabcenters.org. Again, I just ask every provider of drug addiction, alcoholism, inpatient, mental health providers, and legal services for those in need to please get online and list your facilities. There is a free listing, so there is no obligation.
And we're over 2 minutes.
Yeah.
So please wrap
Okay,
up.
thank you.
Thank you.
Yeah, that's fine. Just everybody know that it's free, no obligation, and they can upgrade their listings if they so choose. Thank you for allowing me.
Thank you, caller. And Madam Chair, there are no further participants on the public comment line.
Okay, thank you. With that, we're going to move to agenda item 3, which is the approval of the minutes from the meeting on August 19th, 2020. And then committee, we received a cost estimate from DCFS for their portion of the hearing and what we discussed with them on August 19th. So I'm just going to make sure those get added to the minutes as well. So just so you're aware of that. With that, I will entertain a motion. Well, let me ask, are there any questions regarding these minutes?
Move to approve.
Okay, Do I have a second?
I will
Second.
Okay, so I think we had Dr. Hardy move to approve and Senator Woodhouse seconded first. We will take a roll call vote then. Ms. Kamlasi?
Senator Hardy,
Yes.
Senator Ratty. Yes. Senator Woodhouse,
Yes.
Chair Cohen,
Yes.
Assemblywoman Monk,
Yes.
Assemblywoman Titus.
Yes.
Okay, with that, the motion passes. So we will move on to agenda item 4, the report regarding the committee to conduct an interim study concerning the cost of prescription drugs as required by Senate Bill 276 of the 2019 legislative session. And with that, I'll ask Senator Ivana Cancela, the chair of the committee, to conduct an interim study concerning the cost of prescription drugs, to please provide us your presentation. And thank you so much for coming this morning and giving us this information whenever you're ready.
Thank you, Madam Chair, and thank you, members of the committee, for taking the time this morning to hear about the work we've done over the last few months as part of this interim study. I should note that I think we've broken a Nevada record for the interim study, whose meetings were scheduled, canceled, and rescheduled more than any other interim committee in the state's history, potentially. Not a fact, but it is one I'm working to confirm. And it's a testament to our state's willingness and prioritization of this issue that we ultimately were able to make sure that regardless of everything going on, we fulfilled our work. And I'm really proud of the work we did as a committee and really grateful for the way committee members leaned in despite how challenging our scheduling was. What you have before you is a document that I'll use to briefly walk you through the work, and then certainly we'll take any and all questions. The document starts by outlining the mandate of Senate Bill 276. Our work was fairly broad in scope, but intended to identify ways that we could both lower costs for the state of Nevada and ultimately the prices that Nevadans pay for the medications they need. And it was important that we operated within the scope of the legal parameters that states have on this issue. What we know is that drug pricing is primarily governed by federal law, but that there are ways for the states to be innovative in identifying new ways to interact with drug pricing. We started our work, and I guess you start on page 5 of the packet of our work. It outlines Senate Bill 276's mandate and outlines the different meeting dates we had. As you can see, we were able to fulfill our work within 4 meetings, and I'll talk briefly about each of our 4 meetings and how I attempted to, within that short amount of time, create a broad picture on drug pricing. So we started by looking at the state and the state's work on drug pricing, and we're so fortunate to have experts at DHHS who walked us through not only the work that's been done on transparency across the drug spectrum, both for diabetes and asthma drugs, but also work that has been done on transparency in other pieces of the drug pricing system, on pharmaceutical sales reps, on pharmacy benefit managers, on nonprofits that operate in the health space. And we had folks at DHHS really walk us through the mechanics of how increased drug costs are a burden to our state. And these presentations got deep into the weeds on how programs like Medicaid operate in terms of their drug purchasing, how our different agencies do and don't work together on drug purchasing, and really laid the full picture of the state of events for drug purchasing and drug pricing and how drug costs affect Nevada. In the second meeting, and I should add that we invited some national experts to talk a little bit about what's been done in other states, and would give extra thanks to the folks at NCSL who compiled an excellent report on what other states have done to address this issue and on trends we're seeing across states. In the second meeting, we focused on the private sector, and it was my intention to open the floodgates so that any entity that is interested or involved in drug pricing, regardless of what their position is on different issues, would be able to come forward before the committee and both give a presentation and also have committee members ask questions. So these included presentations by pharma, by the PBM Association, PCMA, by AHIP, which is the American Health Insurance Plan Association. I may be butchering what the P stands for, but in any event, it is a trade group for private insurance plans. We invited nonprofit insurance plans. They were represented by the Culinary Health Fund. We heard from AARP, and we heard from a couple of other private sector interests. The most important voice, though, in my opinion, that we heard from at every meeting were patients themselves who told us about what happens when they can't afford their medications, and who told us about what kinds of changes they would like to see. So at every meeting, we heard potential ideas from patients. In our third meeting, we attempted to take everything we know about what the state does, everything we know about what the private sector does, and then figure out what are the boundaries of what a state authority allows for us to do with all this information. And we had a really thorough presentation by our LCB staffer, Eric, whose last name I'm forgetting at the moment, but who did such a terrific job at outlining what the different federal laws we bump up against when we attempt to take this work on as a state. So whether it's the Dormant Commerce Clause, whether it's patent laws, we really do rely on these federal boundaries. And he also walked us through how little case law exists on state authority related to drug pricing in the context of these federal laws. So while yes, there is a ton of case law on the Dormant Commerce Clause, there's very little specific to drug pricing. And so that creates challenges because as these issues end up in courts, states may or may not defend their bills. And there's litigation across the country right now on issues like transparency, like PBM regulations. And we as a state have to be mindful of that, not only because we want to pass bills that don't end up getting, creating litigation, but also because there are opportunities to seize on these gray or yet unchallenged areas to create new and innovative policy. And we took all of that together to also examine what were, I think, somewhere between 18 and 25, I don't remember the exact number, recommendations that were put forward by all these different groups. And we looked at those as a committee and ultimately came out with 5 bill draft requests, and I'll walk through those briefly. The first bill draft request was one we added during the last meeting. And if you're following along in the packet, we're on page 7. So the first recommendation came from a presentation that we heard in our third meeting that deals with inter and intrastate drug purchasing. So in state, we have a bill draft request that would grant the authority for DHHS to work across agencies to pool needs in order to enhance our drug purchasing power. So for example, what if Medicaid worked with PEB, worked with corrections to purchase hepatitis drugs, as opposed to having corrections purchasing those drugs on their own? could that purchasing coalition ultimately lower the costs on the state? And there's reason to believe it would. We also looked at what would happen if we partnered with other states. So what if we did what's happened in the Pacific Northwest, where a number of states have banded together to purchase drugs as an interstate entity, where they're able to share the ultimate costs and thus create reductions in prices for patients. I thought it was one of the most interesting presentations that came before the committee and really highlighted just how creative states can be, not only by banding together with each other, but with the entities in their states that are interested in lowering their drug costs. So they have partnered with private and nonprofit insurers, they've partnered with municipalities, and have built out their purchasing muscle. The second proposed bill draft request deals with pharmaceutical sales representatives. Today, we are one of a handful of states that has said, we want all of the data that is captured within the Affordable Care Act Sunshine provision, that the Sunshine Act. The Sunshine Act is a provision of the Affordable Care Act that dictates what pharmaceutical sales reps have to report out each year. As a result of that data in Nevada, we've learned that pharmaceutical sales reps who are now registered spent a little more than $2.5 million last year as part of their work in working with doctors' offices and doctors. The bulk of that was spent on food and beverage for doctors' offices and doctors themselves. That transparency is now potentially going to take an extra step forward, which would be to license these pharmaceutical sales reps in the state. Thus far, Illinois and Washington, D.C. have similar programs that our legislation could be modeled off of. And it's an important step to ensure that we continue to receive these reports and also that we build on the law we currently have on the books. The third piece of legislation deals with transparency. Today, we have transparency mandates on asthma and diabetes drug manufacturers. And as a result of that transparency, we've learned quite a bit about how manufacturers in both spaces operate. It's data that helps us as a state not have to look to trade associations or entities with special interests in the matter to be able to make policy decisions. This bill draft request expands on the transparency that currently exists for asthma and diabetes drug manufacturers and for pharmacy benefit managers, and says that it will go farther and apply to all drugs that exceed medical CPI within a year. The intention is to be able to look at the drugs that are significantly increasing in price and be able to answer why that is. The fourth bill draft request deals with pharmacy benefit managers. This is a broad bill that really digs in on pharmacy benefit manager contracting, that looks at whether or not pharmacy benefit managers should have to have a fiduciary responsibility to the state, and that allows for different audit rights and different, enhanced rights on behalf of the entities that are contracting with a pharmacy benefit manager, whether it's the state, a private insurer, a nonprofit insurer, or municipality. And the intention is to dig in on the second, in my opinion, biggest piece of the drug pricing chain, which is the pharmacy benefit manager, the first being the manufacturer. So this is a catch-all bill, and there is great testimony on this potential BDR from PCMA, which is the PBM Association, as well as from the Culinary Health Fund and AARP. And being able to have that robust engagement prior to session is what I think will make this bill draft request really meaningful for our state. And finally, and finally, we have one last bill draft request, and that deals with co-pays and with deductibles. This was a bill draft request presented by Pharma and is intended to deal with the front end as to what patients pay when they pick up their prescription drugs. Altogether, we have a package that had only a handful of unanimous votes, which to me is indicative that we're prepared to have some really tough conversations on an issue that is indeed multifaceted and complicated, and that we should all be digging in on, because no one should have to decide whether or not they can afford the medicines they need to stay alive. So thank you for the indulgence, and at your discretion, Madam Chair, if there are questions, I'd be happy to answer them.
Thank you very much for the presentation. We do have some questions. I've got a question from Dr. Titus to begin with.
Thank you, Madam Chair, and thank you for the presentation. I know it has been challenging to have these meetings, but they're so important, and this issue has been important for several sessions, so thank you. A couple questions on your presentation, especially if we'll start with number 5, the suggestions for number 5. I'm curious as to, you said it came from Pharma, this particular one. I want to know how it was picked to have at least half of the health plans included, and what happens to the other half, and how will that be decided, number 1. Number 2, the flat amount prescriptions, is that going to be stable throughout even though the cost of the drugs might change? And then the last one was the limited co-payments for, and how that's going to work, and will that be all of them or just that half? And then I have some other questions.
These are great questions, Dr. Titus, and we agreed that this BDR should move forward, but did not answer these specific type questions as we were working in committee. I think these are the kinds of questions that we'll work on in drafting, and that committee members will give feedback on once we have a piece of legislation. It's my opinion that, and this is me speaking as Senator Kinsella, not at all representative of the other members of the committee, but it's my opinion that we're going to have some challenges in answering some of these, because what health plans get this benefit and what health plans do not, I'm not sure that there's a formula for that. It may end up being that all health plans fall to this. We also have to navigate ERISA and whether or not there are certain health plans that are inevitably exempted because of federal preemptions. And we'll have to decide how to ensure, to your point, that these stay constant regardless of changes in prices. So these are great questions, and ones that I will take back to drafting as we are figuring out the language for this bill.
Great, thank you. I know this is a heavy lift, and happy to be a participant and all along, because I think it's really important. The next question, if I might have, Madam Chair, if that's all right with you. I have a question regarding the purchasing and the intrastate and interstate purchasing agreement. I'm sure you know now that your members of your committee are getting way educated on the pharmaceuticals and where they're produced and how do you purchase them. But a lot of our drugs are now international. A lot of our drugs that are safe drugs. I mean, I think we need to make sure that these pharmaceutical companies are international companies, and that many of these drugs are not produced in the United States. A lot of our patients go to Canada to get their drugs. And so I'm just wondering if there's any thought to international purchase of these pharmaceuticals.
So I should have said this in my overview of meetings, because it was something that we talked about quite a bit. Nevada has a law on the books that allows for us to partner with Canadian pharmacies to import drugs. It's a program that's been on the books but never fully utilized. And we dug in a bit as to why that is, but weren't able to deduce a definitive answer. So there is potential to explore international drug importation. It's something that I know Florida passed in their last legislative session. And it's a way to look for cheaper drugs. The intention of this potential BDR is not to focus so much on international importation. Rather, it's to work within current purchasing structures. To the degree that there is already purchasing happening from international manufacturers, then that may be a place where we explore this, but it was not in the presentation from the folks in the Pacific Northwest and from our folks at DHHS. International purchasing was not part of the conversation.
So just for clarification, thank you for that. If there wouldn't be, since we already have an agreement with Canadian or some sort of agreement, I'd be curious. I'd like to follow up on that a little bit more. And at some point I'll do that on my own and look for that particular, document or legislation or wherever that is. But I think it's certainly something we can pursue, but I want to make sure this doesn't negate that this wouldn't limit us and not be able to do that. And so I think that it would be okay to continue to pursue the Canadian option.
Yes, we're already able to work with Canada on drug purchasing. And I will send you, if it's not part of it would have been part of the second committee meetings agenda items. If it's not there, then I will send you what we received from legal, just explaining where it is in statute and what the legislative history was on the Canadian purchasing. It is not the intention of this bill draft request to in any way affect that statute or to limit its expansion.
Great. And thank you again. Thank you for the questions and thank you for all the work you put into this.
Okay, do we have any other questions? I know that a couple of our members, Assemblywoman Monk and Senator Hardy were on your committee, so they're well versed in this. And I'm sorry if you addressed this already. I had some connectivity issues, but I did hear where you were talking about how many attempts were made to have these meetings because of COVID and the rescheduling. So with our citizens being kind of in the same position themselves during that time and dealing with lots of issues in their own personal lives and maybe not being able to follow along at that time, but maybe now finding out about this committee is the best way if a Nevadan wants to make sure you've got information, got their story, what they want you and your committee to know as you get into the drafting phase, as you get into moving these BDRs forward, is the best way for them to contact the committee through the website, or is there another way you want them to get a hold of you?
They can certainly contact me directly as the chair, and I'll disseminate information to committee members and make sure it gets to legal or constituent services if appropriate, and can also reach out to the email address on the website. Either way is great, and would love to hear from folks.
Great, thank you. And then again, I'm sorry if you covered this and I just missed it with my connectivity issues, but I was interested in the number 4 with the PBM legislation, the making PBMs fiduciaries. Is that something that's come out of that you saw from another state? And if so, how has that been working from what you've seen?
So this actually has an interesting Nevada history. We included this in 2017 as part of Senate Bill 539, which was the diabetes transparency legislation. It became law. It was repealed in 2019, and we were one of the only states to have put this on the books. Other states have looked at it, but it hasn't become law that I'm aware of in many states. And it seems to me, based on what was done in 2017 and the lack of debate around it in 2019, that we should at the very least answer the question of why we made the change between the 2 legislative sessions and have a definitive answer as to which way we want to continue to move forward in Nevada. I'm especially interested in this because pharmacy benefit managers operate as the negotiator between manufacturers and insurance plans. And when that insurance plan states, municipalities, drug purchasing entities, and when the entity on the other side of that is a public entity like the state of Nevada, it seems to me the fiduciary duty, which is a legal term of art, should apply to some degree, so that states, municipalities, and other entities, even for-profit insurers, are being met with their financial best interest top of mind, rather than a pharmacy benefit manager's profits top of mind. Now, there is clearly a mixed sentiment on this in the state based on what we've done as a legislature. And so this would allow us to make a final determination as to what our position is as a state.
Thank you for that. Do we have any other questions? Okay, seeing none, thank you so much for your presentation, and I will remind any members of the public who are watching that these are the beginnings of the conversations, and your participation is welcome, and we definitely want, these are important issues to Nevadans, and we want to make sure that you understand that your participation is welcome, and these BDRs tend to change and as they become bills, and there's lots more opportunity for participation. So thank you again, Senator. And with that, we are going to move on to agenda 5, which is agenda item number 5, which is our work session. The work session document is available on the committee webpage. At the beginning of the interim, we decided to focus our work on public health, behavioral health, and maternal and child health. And the recommendations we consider today reflect those priorities, as well as issues that emerged as a result of the COVID-19 pandemic. These recommendations were proposed during committee meetings and in response to the formal solicitation of recommendations we issued in the spring. With and I will again remind people, just as I was saying in the last part of our meeting, that these BDRs are the beginning of the conversation, and the public is certainly welcome to participate if these BDRs go forward in crafting the legislation that they end up being. With that, I will turn this over to Ms. Kamlasi to see if she has any remarks taking us into the work session.
Thank you, Madam Chair. Megan Kamlasi, Committee Policy Analyst for the record. As LCB staff, I neither support nor oppose any policy or piece of legislation. The work session document is available online for committee members and the public under agenda item 5. And this document has been prepared to assist the committee in determining which legislative measures it will request for the 2021 session of the Nevada Legislature, as well as other actions the committee may endorse. The members of the committee do not necessarily support or oppose these recommendations that are included in the work session document, but the proposals have been compiled so that committee members can review them and decide whether they want to accept, reject, modify, or take no action on the recommendations. As a reminder, the committee is limited to 10 legislative measures, which includes both bill draft requests and requests for the drafting of resolutions. And the committee may also vote to send letters of recommendation or support and to include statements in its final report. Any votes regarding recommendations will be taken today as roll call votes. And for clarity, members, please use the terms yes or no to indicate your vote. And then please be advised that LCB staff, at the direction of the chair, may coordinate with interested parties to obtain additional information for drafting purposes or for information to be included in the committee's final report. So at this point, Chair Cohen, would you like me to move into the first recommendation?
Please go ahead.
So the first recommendation on page 1 of the work session document was submitted or discussed by Dwayne Young of the Division of Healthcare Financing and Policy at the committee's December 11th meeting. And it proposes legislation to require Medicaid to reimburse the services of community health workers who provide services under the supervision of a physician, physician assistant, or advanced practice registered nurse. And I believe Mr. Young is available to answer any member questions.
Committee, any questions? Dr. Titus, go ahead.
Yeah, thank you. And thank you, Madam Chair, for the question. I'm curious about what the estimated cost would be. What do you see? How many providers do you think we have? During our interim sessions, we reduced provider reimbursement rates, and I'm just curious as to where this will put us. I'm not saying I don't support it. I'm just saying we should know the cost of this decision.
Madam Chair, I think I may be able to address that one.
Oh, okay, please go ahead, Senator.
Thank you, Dr. Titus, for the question. So the community health worker proposal has come forward a couple times in the last couple sessions, but I believe that the testimony that we heard during the presentation on this was that it would be cost neutral, that the community health workers were able to do some things at a lower level that would actually reduce costs of Medicaid. I don't know that for a fact, but we really won't know, of course, the full cost until we get the fiscal note in the regular legislative session. So I've have had the community health workers meet with me multiple times pressing how important this issue is. And so I'm hoping that we can support this out of committee because that fiscal note will really give us the answer. But my recollection was this was either cost neutral or cost saving.
Right, and I appreciate that too, because I think that's, again, it would be not very responsible of us if we don't note that there's a potential cost, but if at the same time we can note today that we anticipate there's going to be a savings to Medicaid if we move forward with this, and that's really where I was going, because I think it's, the conversation of cost and money and budget can't go unnoticed or unnoted. And so as long as we're making sure it's our belief, and it is truly my belief also, that if a community health worker gets out into the public and perhaps intervene so that patient then doesn't have to go to the hospital, go to the ER, as we know it's much more expensive. I just wanted to go on record of saying that this will actually be or potentially be a cost savings for Medicaid, not just cost savings, but definitely, I think, a good healthcare intervention. So thank you.
It's my dream someday that we could get fiscal notes for interim BDRs. That would be a wonderful, wonderful thing, but I know it'd be an awful lot of work for everyone. So thank you.
Thank you. And with that, Mr. Young, if you're here, do you have anything to add to that? Okay.
Move to approve.
Okay. Well, before that, do we have any?
Can you hear me?
Oh, okay. I'm sorry, Mr. Young, are you there?
Yes, can you hear me?
Yes. Did you have anything you wanted to add?
I would just add to Senator Ratty's statement that, of course, when we brought this measure before, at many times it's been budget neutral, and that's dependent upon Medicaid caseload. And there's varying factors within Medicaid. And so when we did the calculations prior, there was a very small fiscal note, but that can often be absorbed depending upon where our final caseload that's legislatively approved falls. And so in previous years, that is correct that it has been able to be absorbed or budget neutral. And we've been able to demonstrate cost savings. And I think one of the important things that has not been factored into any of our calculations is that right now during this pandemic, community health workers would pay, if they were reimbursed, would be playing a vital role in our cost saving system and in our healthcare system, as far as contact tracing and as far as being able to help physicians and providers manage people with chronic diseases. And that's not something that we've been able to calculate yet, because obviously this is a new situation for all of us. But had we had those services approved, they would continue to play a vital role in really fighting COVID-19.
Madam Chair, may I ask another question? I'm sorry.
Oh, go ahead.
So that just comes to mind with, and thank you for that, but since the majority of our Medicaid patients are now assigned to a managed care organization, will we mandate that these managed care organizations have to have these community health workers on their provider network? How will that work?
So if a service is covered by state plan, then managed care has to cover it, and they have to have a degree of network adequacy. Many of the managed care organizations use community health workers now. However, it's not a state plan service, and so therefore it's not mandated, and the division doesn't have control about how they're utilized or when they're utilized, but it's my understanding that our managed care organizations are using their community health workers in the capacity to help with some of this COVID testing and tracing. But if it was a state plan service, we'd have the ability to mandate it across both fee for service and all the managed care plans and have a standard of network adequacy.
Great, thank you very much.
Okay, thank you for that. So with that, I will entertain a motion on recommendation number 1.
Move to approve.
Okay, I believe that was from
Second.
Senator Hardy. Do I have a second?
I'll second.
Okay, a second from Dr. Titus. Do we have any discussion on the matter? Okay, seeing none, we'll now take a roll call vote.
Senator Hardy,
Yes.
Senator Ratty,
Yes.
Senator Woodhouse,
Yes.
Chair Cohen,
Yes?
Assemblywoman Monk,
Yes.
Assemblywoman Titus.
Yes.
Okay, with that, the recommendation will pass on, and we will move on to recommendation number 2. Ms. Kamlasi, comments, please?
Thank you, Madam Chair. Megan Kamlasi for the record. The second item in the work session is to include a statement of support for health in all policies in Nevada in the committee's final report. Health in all policies is an approach to addressing the social determinants of health and supporting health equity through collaboration between public health entities and non-traditional stakeholders. This item was raised by Gerald Dermott of the School of Community Health Sciences at UNR at the committee's February 19th meeting. And you have a little bit more information about health in all policies in the work session document.
Thank you. Committee members, are there any questions? Okay, with that, I will entertain a motion on recommendation number 2.
I will move approval.
I believe that was Senator Woodhouse.
Second.
Second from Vice Chair Ratty. Do we have any discussion? Ms. Kamlasi, if you'll please take the roll.
Senator Hardy,
Yes.
Senator Ratty,
Yes.
Senator Woodhouse,
Yes.
Chair Cohen,
Yes?
Assemblywoman Monk,
Yes.
Assemblywoman Titus.
Yes.
Great, and thank you. With that unanimous approval, we will move on to number 3 in the work session document. Ms. Kamlasi?
Thank you, Madam Chair. Megan Kamlasi for the record. Item 3 was submitted by representatives of Dignity Health St. Rose Dominican and the Empowered program, Empowering Mothers for Positive Outcomes with Education, Recovery, and Early Development. We heard from a couple of folks who started this program at one of the early meetings, and the initial recommendations that they submitted pre-COVID had some pretty big fiscal notes. So following the beginning of the epidemic, they reevaluated their recommendations and ended up sending this recommendation to propose legislation to define screening, brief intervention, and referral to treatment in statute. It would also require healthcare professionals who are authorized to provide or prescribe controlled substances in Nevada to obtain 2 hours of continuing education in SBIRT as a condition for licensure or license renewal. And such prescribers would only have to complete SBIRT training once during licensure in the state. This proposal also would allow completion of approved SBIRT training to fulfill existing continuing education requirements related to substance use for prescribers. It would require training to be completed by January 1st, 2024 for license renewal, and prior to licensure for controlled substance prescribers applying for licensure on or after that date. And then in addition, it would allow a controlled substance prescriber who on or after July 1st, 2021 obtains a waiver to treat opioid dependency with narcotic medications to use that waiver to satisfy the SBIRT continuing education requirement. And this is related to providing medication-assisted treatment for those with opioid dependency. And I believe that Dr. Andrew Peterson is on the line if there are any questions from committee members.
Thank you. Before I ask for questions, I'll just thank Dignity Health and the Empower program for being willing to amend your request with understanding the financial position that the state is in right now. And with that, I'll ask if we have any questions.
Madam Chair.
Dr. Hardy, go ahead.
Thank you. In as much as we're trying to encourage people to get the waiver in order to be able to have medication-assisted treatment with buprenorphine, for instance, I'm looking at this. Anytime you do the waiver, you are encouraged, anything you do for buprenorphine, for instance, to treat a substance use disorder, you are required to marry the counseling part of that with the medication part of that. So SBIRT is an integral part of that process when you're dealing with someone with an opioid use disorder. And so in as much as SBIRT is so critical to that process, as well as even if you don't get the waiver, I'm looking at the waiver probably ought to, SBIRT training probably ought to count for some of the requirement we have for pain management, for instance. And if you have the waiver, then you get to count it. But if we can encourage the waiver by giving even a double 2-for-1, as it were, per hours, if I encourage the waiver and encourage SBIRT, then I will have more opportunities to treat the substance use disorder so that we can allow more and better pain management in the state of Nevada. So this is one of those where I would suggest that not only do we approve it, but we make sure that it counts for the pain management and that we give 2-for-1 credits if they get the waiver out of this. We need to do something over and above thinking out of the 1-hour backgrounds and the encouraging. We need to put our words where our mouth is. This is a critical piece of legislation if we want to do it and get serious about our pain management and as well the marriage of behavioral science to it. So I will be happy to move this and will encourage us to do more than what we've written down so far.
Hey, thank you for that. I'm sorry, I didn't catch the name of the doctor from Empower.
Dr. Peterson is available.
Dr. Peterson, would you like to respond to Dr. Hardy's statement?
Sorry, yeah, this is Dr. Peterson. No, I just want to thank you for your support and then just say that SBIRT is a billable process through Medicaid, so I think that this would be helpful to have physicians, adequately trained in these processes.
Okay, thank you. And then committee members, are there any other questions?
I have a question, Madam Chair.
Please go ahead, Dr. Titus.
Thank you. And thank you for that. And thank you, Dr. Hardy, for your comments also. I have two questions, actually. First, what's the cost of doing this program? We all know that we have a lot of requirements, the CME, et cetera. And so I have a question on what would be the cost to the provider to do this, because you're asking all providers to take this if we have our pharmacy license and we can prescribe narcotics. And is it just for narcotics or is it for all scheduled drugs? That's my first question. Second question is, what's the availability of the program? If you're asking all of us to take this within the next 4 years, that we all have to do this program, a 2-hour program, is it an online service? Is it going to be available? Is it already up and running? And how quickly can we actually do this?
Those are great questions. We have actually been working through the group that we do with opioid use disorder and pregnancy with Dr. Stephanie Woodard, and there are some CEs that are already available through different Project Echoes. So it is my understanding that the state already has some things available, and there would not be a difficult process to create something for the,
So is
for
it
the physician.
only through Project Echo then, so far, nothing online? Again,
There's an abundance of things online for physicians too, and I apologize, I don't know the exact cost of them, but I do know that there's an abundance of different CEs online for physicians to be able to do ASPR training.
So this particular training, is there anything, so if we have a lot of pop-up trainings, or is there anything that the state recognized as appropriate training for this? And that's the other thing, so that somebody doesn't go sign up for one program that's not recognized by the state. So how's that going to be, who's going to guarantee the program that I take is one that's recognized? I mean, how will that all be sought out?
Yeah, I believe that's a good question too. I believe that SAMHSA, and Dr. Woodard is probably better at answering this question than I would be, but I believe the SAMHSA actually has different expert trainings that are available.
And this is Megan Kamlasi. I believe Dr. Woodard is available. So Dr. Woodard, if you're there, can you pop up and provide some information?
Good morning. Can you hear me okay?
Yes.
So yes, ASPERT is a nationally recognized evidence-based practice for the screening, brief intervention, and referral to treatment for individuals who are either at risk for or have a substance use disorder. As Dr. Peterson mentioned, there are abundance of trainings available online and eventually, hopefully, also in person, specifically geared towards the medical community. There are very specific standards that have been set forth already through national organizations. And so moving this legislation forward, we would make sure that we put forth policy to align with those.
Very good, thank you, and thank you for being available, because as you know, we're asking providers to do more, and again, I support it, but I want to make sure that we're not making it this huge hill to climb over when we want to encourage people to be knowledgeable before they write that prescription, but it can't be so onerous that nobody wants to do this. So thank you again for
Madam Chair.
Dr. Hardy?
In the training for your waiver that we're talking about, they allude to and do a training, maybe not 4 hours or 5 hours of the training, but they do training in the ASPERT itself. So it is, and the waiver is free. You can get it through the PCSS program, and you can get it for free, 4 hours online, 4 hours in person, and it's still free. But we need to have more people doing it, and it's not just the free that will entice them, but if we recognize that counts for your pain requirement for your CME, this certainly ought to count for that as well, because it's an integral part of the pain management that we're talking about, or the addiction things that we're talking about. So I would be very generous in the counting of the hours, as well as counting it towards the pain management part of that. Thank you.
Okay, so do we have any other questions or comments? Okay, seeing none, so I think what we have from Senator Hardy is a motion to amend and do pass?
Correct.
Okay, do I have a second?
Second.
Okay, and I think that was from Assemblywoman Monk?
Correct.
Thank you. Okay, so we'll now take a roll call vote on the motion to amend and do pass.
We have discussion.
Oh, I'm sorry, discussion. Do we have any discussion on the motion to do pass?
I just want to make sure that I understand the amend part of it. So is the amend to also have this training be credit towards obtaining a waiver and credit towards the required pain management hours. Is that the amendment?
Correct.
Okay. And Dr.
The
Wood,
twofer.
so I'm not sure that we heard from Dr. Woodard. I just want to make sure that logistically, practically, that makes sense. That we're getting it right at this point, if you will. So Dr. Woodard, does that logistically or practically make sense?
So what we don't have control over are what the national or federal requirements are for the waiver. But what we could do is certainly allow people to have the 2 hours of credits for SBIRT to account towards the requirements that were put forth in AB 474, which I believe Dr. Hardy is referring to related to pain management. So that definitely gets us a lot closer to making sure that we are affording the opportunity for individuals who are already required to get CEUs to meet this mandate. And then over and beyond that, Senator Hardy, I believe what you were talking about was potentially even amplifying the number of CEUs that could be granted for an individual if they have a waiver, not necessarily that these training hours would count towards their waiver. So I guess that would be a question of clarification I would need to ask first before I could answer the second part of that question.
If I may.
Please.
To get the waiver, there are criteria that we don't have control over. But we do have control over what we've made a law for. And so to amplify and get 2 for 1, yes, that is where I would be going with that. But likewise, when I do 2 for 1, or when we would do 2 for 1, and I would say, and the SBIRT training would count for the pain management requirement that we have in the state. It won't do away with the federal requirement that we have to do for the waiver. That's separate and distinct that we don't have control over. So if we really want to encourage, then we encourage the 2 for 1 hours, and we encourage the people who get the waiver to be able to count that as their CMEs or their CEUs. I see my head nodding yes on Stephanie's part.
So Stephanie Woodard, record. Chair, may I follow up?
Please do.
So Senator Hardy, thank you for that clarification. I think then from a state policy perspective, we certainly would be able to grant those individuals who have received their waiver as essentially meeting this minimum requirement and potentially following Senator Hardy's recommendation, providing them with 4 CME credits for that waiver training as opposed to the 2. Senator Hardy, do I have that correct?
Yes.
Okay, do I have any other discussion?
No, just thank you, Madam Chair. I think that was helpful clarification for me to understand really what the amendment does and to feel comfortable that it will be something that we can actually implement. So thank you.
Okay, so with no further discussion, we'll take a roll call vote.
Senator Hardy? Senator Ratty?
Yes.
Senator Woodhouse?
Yes.
Chair Cohen?
Yes.
Assemblywoman Monk?
Yes.
Assemblywoman Titus?
Yes.
And Senator Hardy, are you there? Is there and not there, Chair Cohen? Not sure which
Okay.
one.
Maybe we will take a brief recess while we try to make sure that we've got Senator Hardy connected. So we'll go ahead and be in recess. I understand Dr. Hardy is back connected. So with that, we'll come back to the work session and move on to number 4. Ms. Kamasi, if you would please go forward.
Thank you, Chair Cohen. And can we just confirm Senator Hardy's vote on item 3? Oh, did we lose him?
This is Wakanda Carter from Broadcast and Production. We might need to give him a moment to connect his audio.
Okay, sounds good.
Okay, this is Wakanda from Broadcast and Production. Senator Hardy, are you on?
I am on.
Lovely. Awesome. Okay, you may continue.
I think Senator Ms. Kamasi wanted to confirm your vote in the last, for number 3.
It was yes.
Great. Okay, thank you. So with that, we will move on to number 4.
Thank you, Madam Chair. Megan Kamlasi for the record. Item 4 proposes legislation to require the Division of Healthcare Financing and Policy to apply for a Medicaid 1115 demonstration waiver to pay for substance use disorder treatment services in institutions for mental disease in Nevada. And it also proposes to authorize DHCFP to apply for an 1115 waiver for adults with serious mental illness or children with a serious emotional disturbance. Currently, federal law prohibits federal payment for services provided to patients residing in institutions for mental disease or IMD facilities that have more than 16 beds. And this prohibition means that Medicaid may not use federal matching funds to pay for services at mental and behavioral health facilities with more than 16 beds. But in recent years, the Federal Centers for Medicare and Medicaid Services have offered a couple of waivers from the IMD exclusion policy. And so this would enable Nevada to pursue those waivers. And I believe Dwayne Young and Dr. Stephanie Woodard are both available to answer questions on this item.
Okay, committee members, are there any questions?
I have a question, Madam Chair.
Please go ahead, Dr. Titus.
Thank you, Madam Chair. My question revolves around how many institutions do we have that have more than 16 beds, number 1, and number 2, again, as I brought up earlier, that we have a managed care program here in our state where the majority of our Medicaid recipients are on managed care. And again, I just want to point out the importance of having our managed care associations, the people that we contract with as a state, make sure that network adequacy includes those institutions. Thank you.
Okay, thank you for that.
There's 2 questions.
Yes, Dr. Woodard, Mr. Young, would you like to address those questions?
We're just pulling up the information on the number of facilities that do provide those services. What I will say is that within, of course, within fee-for-service, we're restricted for paying for those services. Managed care also falls under that rule. However, they do have the in lieu of, which allows them, in lieu of more expensive services that they would be providing for that patient, to provide up to 15 days inpatient a month facilities for that person on a calendar. And so they cannot go beyond those 15 days per month. And then the average length of stay from our data shows that most people are within those facilities for 5 or 7 days. Now, when an individual is seriously and persistently mentally ill, and they do fit under the eligibility code of age, blind, and disabled, they're in fee-for-service Medicaid, and those are the people who are going to need those longer stays, and they rely on our state facilities for those stays. And so, yes, while to answer your question, while there are those facilities enrolled for fee-for-service, there's not a current payment mechanism for them, and they are enrolled in managed care as part of their network for other services, and they are utilized under that in lieu of role. There's really not a gap to catch people who are more seriously and persistently mentally ill and have those longer stays unless they're within the state system.
Okay, not sure that answered my question. So you don't know the number of facilities that have over 16 beds? You don't have a count on how many there are in our state?
Sorry, good morning, Stephanie Woodard for the record. There are at least 10 hospital facilities in Nevada that meet criteria for IMD. And then when we also look at other facilities that could be covered under the IMD exclusion, we could also extend that to our residential treatment facilities. And those residential treatment facilities and detox facilities, the vast majority of them are also IMDs, meaning that they do have beds that exceed 16.
Great. And so along then the second question that I had was, and then you brought this up about the managed care. It appears are already covering these folks. It would be the fee for services folks that would be benefit from this. Is that what I'm hearing?
Yes, that's exactly what we're hearing. Under the in lieu of rule, again, they can cover up to 15 days if they are enrolled in managed care, in lieu of more expensive services that they might have if they were not hospitalized. But fee for service, there is no mechanism because of the IMD rule other than the state facilities. And those, the seriously persistent mentally ill, are usually under the age, blind, and disabled category, which is a mandatory enrollment in fee for service.
Thank you. And then you mentioned network adequacy, and I also had brought that up before. Is there any mandate when you sign with these managed care organizations that they have a contract with a mental health provider, mental health facility, any rules that way for that network adequacy?
There are rules for network adequacy for both inpatient facilities and behavioral health providers.
Very good. Thank you. Thank you for that. Thank you for that. And thank you, Madam Chair, for the questions.
Thank you. Do we have any other questions? Okay, seeing none, I will entertain a motion on recommendation number 4.
So moved.
Okay, I have a motion from Dr. Titus, and I believe a second from, did I hear?
Dr. Hardy.
Yes, from Dr. Hardy?
Yes.
And yes, okay, a second from Dr. Hardy. Any discussion? Okay, seeing none, we'll now take a roll call vote. Ms. Kamasi?
Senator Hardy,
Yes.
Senator Ratty,
Yes.
Senator Woodhouse,
Yes.
Chair Cohen,
Yes.
Assemblywoman Monk,
Yes.
Assemblywoman Titus.
Resounding yes.
Great. With that, recommendation number 4 passes, and we will move on to recommendation number 5. So Ms. Kamasi, if you'll please go ahead.
Thank you, Madam Chair. Megan Kamlasi for the record. Item number 5 proposes to send letters to the Senate and Assembly Committees on Health and Human Services and to the Director of the Department of Health and Human Services, expressing the committee's support for the priorities and goals identified by the Children's Mental Health Consortiums. Their priority and documents and plans are available on the committee's webpage. And this recommendation was submitted by Dan Musgrove on behalf of the three Children's Mental Health Consortium. And yeah.
Thank you. With that, committee members, are there any questions? Okay, seeing none, I will entertain a motion on recommendation number 5.
Senator Woodhouse moves.
Okay, I have a motion from Senator Woodhouse and a second from
Second.
Patty. Okay, and do we have any discussion? All right, seeing none, if we can please have a roll call vote, Ms. Kamasi.
Senator Hardy,
Yes.
Senator Ratty,
Yes.
Senator Woodhouse,
Yes.
Chair Cohen,
Yes.
Assemblywoman Monk,
Yes.
Assemblywoman Titus.
Yes.
Great. With that, number 5 passes, and we'll move on to number 6. Ms. Kamasi, if you will.
Thank you, Madam Chair. Megan Kamlasi for the record. Item 6 was proposed by various presenters at the committee meeting on January 15th. And it proposes legislation to require the Division of Healthcare Financing and Policy, to the extent authorized by federal law, to expand Medicaid coverage to pregnant women, and it includes 4 pieces: increasing Medicaid coverage for pregnant women in Nevada from 165% to 200% of the federal poverty level, implementing presumptive Medicaid eligibility for pregnant women, eliminating the requirement that lawfully residing pregnant women must have lived in the United States for 5 years prior to being eligible for Medicaid, and expanding postpartum Medicaid coverage from 60 days to 12 months following childbirth. And I believe Suzanne Bierman and Dwayne Young from Medicaid are both available for questions.
Okay, committee, do we have any questions? Okay, seeing none, I will entertain a motion on recommendation number 6.
So moved.
I have a motion from Dr. Hardy, and I believe it was the second from Senator Ratty. Okay, do we have any discussion? Seeing none, I'm sorry, does someone have discussion? Okay, sorry, seeing none, Ms. Kamlasi, if you'll please go forward with the roll call vote.
Senator Hardy?
Yes.
Senator Ratty?
Yes.
Senator Woodhouse?
Yes.
Chair Cohen?
Yes.
Assemblywoman Monk?
Yes.
Assemblywoman Titus?
Yes.
Great, and with that, with 6 passing, we will move on to number 7. Ms. Kamlasi, if you will, please.
Thank you, Madam Chair. Megan Kamlasi for the record. Item 7 was proposed or recommended by Julia Peak and Candace McDaniel of the Division of Public and Behavioral Health. Am I muted? I'm good. Okay, cool. At the January 15th meeting. And there are 3 pieces to this proposal for legislation. The first, Part A, revises NRS 442.0101A to clarify when a pregnant woman must be tested for syphilis. And so it clarifies when during the first trimester, the 3rd trimester, and then also that a woman would be tested for syphilis at the time of delivery if deemed high risk. Part B is kind of part of the first, and that would revise NRS 442.020 to make the penalty for violating the piece of statute above a civil penalty rather than a misdemeanor, and that civil penalty would not exceed $500. The second piece of this proposal is Part C, which would require hospital emergency departments and other medical facilities to test pregnant women who seek care in the facility, and to test them for syphilis, regardless of what they are seeking care in the emergency department for, if a woman indicates that she has not had recommended prenatal care. And then the third piece is Part D, which would require screening for chlamydia, gonorrhea, hepatitis B, and hepatitis C for all pregnant women as recommended by the CDC, that's the Centers for Disease Control and Prevention, or its successor organization. And I believe either Julia and or Candace are available to answer any questions. And I believe we also will have Bill Welch or Marisa Brown from the Nevada Hospital Association on the line to answer any questions from the hospital perspective.
Madam Chair,
Go ahead, Dr. Hardy.
I get a little confused when it says and or. So is it and or is it or? Is
Sorry,
it
this is Megan Kamlasi. I should have been clear on that. The committee can choose to pursue any or all of these recommendations, and so, or any combination thereof.
So is Julia Peak around that can say what the CDC actually not just requires, but suggests?
Julia Peak for the record. Hi, Dr. Hardy. We had provided in our very first presentation, I don't know if the slides are still available, to align directly with what the CDC guidelines recommend. We worked with Ms. Kamlasi to ensure that the recommendations you have in front of you align more closely with what the CDC recommends. I think they're a standard of care for the most part, but we did want to ensure that it's written in statute so that we solidify the recommendations ongoing, as opposed to just having it as a guideline or a standard of care.
So, does the CDC say and or does the CDC say and, or does the CDC say or?
Oh, great question. I apologize. I didn't answer that clearly the first time. Julia Peak, for the record, the CDC would say and, they would be all bullet points for the recommendation. So what we've provided you, if you've selected and, with the one exception, testing in the emergency room for women who hadn't had prenatal care. The Centers for Disease Control and Prevention sent out a team earlier in the year to look at our congenital syphilis and opportunities for intervention. That was a recommendation that they had for us. We had been trying to implement something similar prior. One of the biggest challenges that we had is that there's a challenge giving the woman the result of the test prior to her leaving the emergency room encounter, but public health would be notified of that, and then we would be able to follow up with her. So that was a guideline provided or a suggestion provided directly to Nevada during that visit from the Centers for Disease Control and Prevention. I don't know that they have it as part of the standard screening on their website.
So the bottom line is the CDC came to Nevada and said, number 1, number 2, number 3, and then under B, they said, don't make it a crime, but make it a civil penalty. And C, they said to do it. And under D, they said to do it as well. So they said all of those?
Julia, for the record, some of those is just cleaning up the language in 442. It's similar in 441A where it is a criminal misdemeanor. It's just a challenge to implement something like that, and we would not do it under any circumstance. So that's a combination of the CDC guidelines that are posted publicly for all states. It's part of the direct intervention that we had related to congenital syphilis in Nevada, and then just cleaning up some language when we were going over it with Ms. Kamalasi to make it more easy to implement in our state. And then if we do have misreporting or underreporting, we can follow up directly with the clinician or facility, and it wouldn't be a criminal misdemeanor. It would just be a fine. So a combination of those very 3 specific things posted nationally as a recommendation or guideline specific to Nevada during that site visit, and or just cleaning up the language.
So you're anytime you use the word and or, then I get confused. Number 1, I need to make it a civil penalty instead of a misdemeanor. I need to do that. Number 2, I need to test them in their first trimester, their third trimester, and at delivery and in the emergency room. And number 5 or 6 need to screen for chlamydia, gonorrhea, hepatitis B, hepatitis C, as recommended by the CDC. Is that what you're saying?
Julia Peak, for the record, if you did the and for all of those scenarios, we would be giving our moms and the babies the best possible screening based on the guidelines, and then additional screening based on our high rates of congenital syphilis. So if you were to go with the and statements instead of the or statements, I think we'd have the best policy to put forward.
If we put the ors in there, then it's not required at all.
Julia Peak, for the record, some things would be required. You'd just be pulling out the different parts that you support. So for example, if you supported the first section, but you didn't support the testing in the ED, that's absolutely something you can consider. And Ms. Kamalasi has given you that option. The and statements, again, would be the most comprehensive screening for our moms and babies.
Appreciate it. Thank you. I'd love to have the hospitals weigh in on emergency stuff.
Mr. Welch, is you available?
Yes, Madam Chair, I am present. I did get a chance to talk with Ms. Kamalasi in the last week and a half about this, and we've done some research to identify a number of potential patients who would be impacted by this requirement. First, I'd like to start out with using data from 2019, which is the most complete data we have for a year. We see approximately 1,100,000 patients in our ERs annually. Of that, we would estimate that slightly more than those are female, and of the 500,000+ who would be potentially female, there would be somewhere between 200 and 300,000 women who would be in the childbearing age category. With that being, so there would be 200 to 300,000 women that we would need to ensure that we were asking the question as to whether they were pregnant or not. Currently, when a woman presents to the ER, unless they are presenting specifically for a pregnancy-related issue, and we do have about 1,000 of those type of cases a year in the hospital, but for the general female population, they would not be asked the question of whether they were pregnant unless they were going to have certain type of medical examinations done, particularly related to radiological procedures. They would routinely ask if the woman was pregnant to ensure that they were taking all the precautions necessary to protect the baby. Of those total number of female patients who potentially would be need to be screened, at least from determining whether they were pregnant or not, about 16,000 of them are insured, and we would guess that most of those patients are getting prenatal care. There are in excess of 15,000 of the patients who are Medicaid or some other subsidized program, and we believe that most of those women would also be receiving prenatal care at some point in their pregnancy, but it may not be immediately because some of the women become eligible for Medicaid after they've been identified as being pregnant. And then we had a little over 2,000 of the patient population who in fact are uninsured and not likely to have any prenatal care. We do have a couple high pregnancy risk centers in the state, and these centers do try to accommodate and address the uninsured population as best as possible. But obviously that is something that's voluntary on the patient's behalf as far as whether they utilize those facilities or not. The cost to perform, and this is the cost to the hospital, this is not the cost that would be charged, but the cost to the hospital to perform the basic syphilis test ranges from $90 to $113, depending upon which reference lab is being used. If the patient tests positive and they do follow-up tests, the test cost to the hospital again is $186 per case. Some of the challenges that we see is ensuring that we modify and get all of our staff orientated to make sure that they're having this as a standard questions. We have so many questions that we're screening patients that are coming into the hospital now. It'll take a little time to make sure that we are able to make sure that this is on the checkoff list and that we're getting that question asked of all female patients who would be in the childbearing range of age. The test results in most cases are not coming back for 3 to 5 days. And so the hospital's not going to know whether the patient was confirmed to have syphilis or not until days later in most cases. And so then there's the issue of who will do the follow-up with the patient if they are in fact confirmed to have syphilis. As we've talked with representatives from the state, it's our understanding that it would be public health. But we would say that currently we know that public health is stretched to its max, and we routinely do get asked to help them, and we do our best to do this, but to assist them in following up with patients that otherwise would normally be followed up with public health. So that would be something that we would want to make sure is in fact covered, because this potentially could be a significant number of individuals. Then there's the responsibility of who will report this to the state public health. As we understand it, the state labs and the labs are required to report this, so that should address that concern from the hospital's perspective. And finally, just have to bring it up, but on payment, as I look at this list of the number of tests that will be required, there may need to be some provision in the law as you move if you move this forward and how you move it forward to ensure that third-party payers recognize that this is a procedure that we are being required to perform, and that they would need to reimburse for those tests, not procedures, but tests, and that they would need to reimburse for those tests. I'm not clear how it works for the physician's office, because a lot of this would, in the first couple phases of the testing, would be done at the physician's office. So I'm not sure how the payment arrangements are with physicians, particularly. I believe that it's similar to the hospitals, but we are on a per diem rate, and that per diem rate is to be all inclusive of whatever we need to do to meet the women and the baby's medical needs at the time of delivery. So we would ask that there be some consideration, if this were to move forward, that there be provisions to ensure that there's acknowledgement that there will be reimbursement. This would be a similar situation for Medicaid, at least with the hospitals again. Medicaid for those patients who are in the hospital. So this would really relate to the patients who are delivering and have delivered in the hospital, and then we're performing these tests at that time. We would want to make sure that that wasn't automatically assumed to be part of the per diem rate that's already been established in the fee schedule that didn't include this cost. I guess the last thing that, and we've talked with the state about this, and we certainly want to work with the state. We understand Nevada is ranked, we believe, number 2 in the nation, and we certainly need to do something to address that. But we would also make sure there's been a lot of legislation in recent legislative sessions about patient rights, et cetera, that we would want to make sure that there was provisions in the legislation that if a female patient refused to have the test done, there would be clear direction on what our responsibilities were and or how we would handle that, so that the hospital itself would not be in penalty if the female patient refused to allow us to do the test. And so that was the information that I wanted to provide to you today, but I'm happy to answer any questions as best as I can.
Thank you, Mr. Welch. Do we have any questions for Mr. Welch?
Well, I guess I had the same kind of questions when I look at the mandate. I think that there could be a problem with the mandate. I appreciate the civil penalty, and I think the ors may be better than the ands. It may not be perfect, but it may get something done. That's kind of where I'm coming from on that one.
Madam Chair?
Please go ahead.
Thank you. And thanks, Dr. Hardy, because I had the same concerns and questions regarding that portion of this legislation during the 2019 session. I multiple times commented that I was appalled that Nevada was number 2 in congenital syphilis, and that we needed to come and make a change to make sure that we improve those numbers. And one of the ways to approach that is the presumptive eligibility, which we all just supported on a prior bill. This particular piece of legislation, I'm not sure gets to really the problem here. We know that, at least I think, a lot of the women that we identify ultimately at some point, post-delivery, et cetera, did not have any prenatal care. So mandating that they come to the emergency room without saying who's going to pay for this, and also whether a patient accepts that, that's one of my big things, that is that the patient has a right to refuse this test also. So then who, as Mr. Walsh said, who's going to be responsible for that? Or if there's a liability, who's going to be liable for that? And that, but my question would be, based on this particular recommendation, when it says civil liability, is it the emergency room provider? Is it the hospital? That's number one. Number two, a lot of these folks they may not be in a hospital setting. So what's that definition if it's in a private practice office? And then the third thing would be, we do have home deliveries. We have midwives. We have some of those out there, birthing centers. Would they be included in this? I'm just wondering about how this breaks down, and just really, we need to do something. It's not acceptable that we're number 2 or any rank. We need to improve our numbers. And so I'm just not sure the emergency room component gets to the heart of this issue. And at the same time, undue burden, and who's going to pay for those tests? And then how does it work if a patient refuses?
Madam Chair.
Please go ahead, Senator Rowdy.
So first of all, I just want to clarify the process because I think there's been a little bit of confusion about the and or. So the and or is just for us in this work session to choose whether or not we're moving this forward, right? So we wouldn't write legislation that had and or in it. So basically we should be looking at these as 4 separate standalone ideas, and we're moving them all together in one bill, but we're just deciding which ones we're going to move. It wouldn't say or in the legislation giving options. It would just be, we're just choosing not to move that one forward. Am I understanding that correctly?
Yes, that's correct.
Okay, great. So then, I would, first of all, I'd like to thank Bill Welch and the Hospital Association for clearly taking a good chunk of time and reaching out to the members and getting us some good feedback. And I think there are many things that were brought up. It reminds me a little bit of the newborn screening bill from last session, and the whole conversation about the daily rate for births. Maybe a little bit of PTSD you just caused for me there, Mr. Welch, of how do we have this conversation when all of the pregnancy is bundled into one payment? So I think those are legitimate concerns. I'm not sure that we can get to the level of detail based on how many conversations that took in today's work session, but I just want to put on the record that I think that how these get paid for is a legitimate concern that should be addressed and as this bill moves forward. But what I heard from Ms. Peak, and I just want to make sure that I understand this, is that our syphilis rate is so bad in the state of Nevada that not only are we making changes 1 and 2 to revise our existing NRS to strengthen it and to make it more realistic, but you're bringing forward recommendations 3 and 4 because the CDC came to the state of Nevada to do an intervention and provided these recommendations. And so I would like us to move forward, including all 4, knowing that we have 120 days to have this conversation to see whether or not it makes sense, to see how we would pay for them, to do all those things. But I would hate to eliminate recommendations that the CDC provided to the state of Nevada to address this issue here at the work session stage and not have the opportunity to have that conversation. So I just want to recognize those legitimate concerns, but also say that I'd like to see it move forward. I also think perhaps a simple amendment that we could do today would be to add that the patient has the right to opt out. And so that is clear from the get-go that the patient has the right to opt out. That seems to me like relatively simple thing that we could all agree to today. So those are my thoughts.
Thank you for that. So going along those lines, I just would like our council just to confirm that there are other tests. And I don't know, maybe Mr. Welcher or Deputy Administrator Pete can chime in on this, but I believe we have several other tests that citizens can opt out of when they're in the hospital or the emergency room setting. So this would be no different than that. Is that correct? If we decided to put it in an opt-out provision?
Julia Peak, for the record, yes, I would recommend this be an opt-out opportunity. Again, you wouldn't be forced to provide the test. You'd offer the test, and I think the points that Mr. Welch brought up on behalf of his association, I think those are all very good and valid points. I'll just add specifically to what several of you have mentioned, the first section where we fix the first and third trimester to be more specific, that is based on data as well, as is the recommendation for emergency departments, specifically Dr. Titus, not the wide variety that you spoke of earlier. This is specific to emergency departments because as we look at these moms that we've identified during birth that had syphilis and then the baby then had congenital syphilis, they went to the ER. Many of them, I could get you the exact data, went to the ER for an unrelated reason and could have been offered a test. And so it's a missed opportunity that we might have been able to find that mom earlier in her pregnancy. And then again, the emergency room is based on the information. So those are two data points that we found when we looked at our congenital syphilis cases. The other recommendation that I might make is perhaps within the statute, you identify either not a sunset per se, but if our rate of congenital syphilis gets to a much lower level, perhaps that testing is not needed because we have such high rates now. That's the reason the CDC recommended it. Those would be my suggestions. If I didn't answer the question, please let me know. Happy to try again.
No, you answered the question and what was going to be my next question about the emergency room. So then I'll ask, is that?
Wait, I'm not sure my question was answered though. I had multiple questions in that and I'm, again, who's going to be liable is, as you clarified, perhaps it was just the emergency rooms, but are you going to expand it at some point to offices, all providers, et cetera? Number two, the payment process, which has been brought up already. Yes, the patient can opt out, but who's going to pay for it if they opt in? And is it going to be a mandate for the who's going to cover? So if a patient has no coverage, which we know part of the problem is most of these moms have no coverage and they don't get care, maybe they show up in the ER for some unrelated problem, or maybe it's the pregnancy. Yeah, absolutely, there's a standard of care where you test for these, especially high-risk moms, but it should be tested for anybody. It doesn't, it's an interesting criteria. It makes you high risk. But I would say that if you show up in the ER, it's great to be tested, but to offer someone a PAP when they're in the ER, when I'm in the ER, there's no way I'm doing a PAP on somebody. It's just not possible. We're in my little emergency room. It's not set up to do that. Can we do blood tests? Certainly. But then who's going to cover that? Who's going to pay for that? And again, I think I'm not comfortable including C in there unless we work this out, at least with some understanding before we move this forward. I'm for A, B, and D, but not C unless I have some understanding about process, liability, and payment before we move this forward.
Madam Chair.
Sorry.
Well, I think Dr. Hardy, let's let the Deputy Administrator answer those questions first.
Julia Peak for the record, thank you. So related to the liability, so within NRS and NEC, both the provider and the facility are required to report, as is the lab, the identification of a case. The most timely report out of all of those is the laboratory report. So upon getting that, we begin to reach out to the woman and try to get her the treatment needed. But there's liability identified in NRS and NEC 441A for review. Related to the payment process, I think that's something that the committee should discuss and figure out what that looks like. We can provide additional data on the number of pregnant moms by insurance provider. Also, as you talked about earlier, presumptive eligibility is definitely an option that could be considered to support those fees.
Okay, Dr. Hardy, please go ahead.
I'm on a limb probably. I suspect that the high rate of syphilis, gonorrhea, chlamydia, etc., are probably highest in the people who aren't getting prenatal care, who haven't initiated the first trimester, I'll call it, prenatal care. So I think we may be trying to do something that we don't need to do. So if you take we're the top two, are we the top two? We're probably the top one if we didn't figure out the people who were getting prenatal care. So Julia, do you have kind of demographic statistics that bear out who we need to check and who we need to not necessarily not check, but how aggressive we have to be at the time of delivery, how, what is it that we're needing to do?
Julia, for the record, we'd be happy to provide you with the data. We did prepare an epi profile. We're also working with the University of Nevada, Las Vegas to do much more in-depth clinical review of the cases than what we get in just surveillance data. So your comments about these women may traditionally have lack of insurance or other issues. They also have comorbidities, including some substance use disorder and others. So we have data both on demographics, comorbidity, insurance type. Happy to provide that to the committee for their review.
I appreciate that. We're probably not going to have that come back to this committee because as I understand it, this is the last one. On number one, A1, the first trimester of pregnancy at the woman's first visit or as soon as practical. A woman could come into a doctor's office, for instance, in her first trimester, and it's not for pregnancy. And so then it turns out 2 months later that now I'm at 15 weeks or whatever, and now I know that I'm pregnant, and oh, I should have had that done, but you didn't, and then therefore you have a civil liability that you have to pay for because you didn't do it in my first trimester. Teach me. Who's that apply to?
Julie, for the record, I think that question was directed at me. So we tried to add language in there as soon as practical after knowing. So first and third trimester. The data point related to this that we were trying to address is we were seeing moms come in after the first trimester and then would not be tested till the third trimester. And so we want to make sure as soon as is possibly practical after she's been identified, if that's second trimester, the liability wouldn't fall to the physician for not testing in the first trimester if they didn't know that she was pregnant. They just need to test her at the point that that they see her again, first trimester, second trimester, or third trimester.
Let me make it simpler than that. If a person comes into the family doctor for a cold in her first trimester and doesn't say and doesn't even know that she's pregnant, so is that family doctor or is that CVS pharmacy urgent care person? Does that count as that first visit? Or is it the first visit for her pregnancy?
Julia, for the record, so it would be related to her prenatal care visit. So with her OBGYN, then we added the additional, I know you were just talking about that first section, but to jump to the or section with EDs, it would be emergency departments, that type of facility, or related to your prenatal care, where it's the first, second, or third trimester, not your family doctor or an unrelated visit.
I appreciate that. Thank you, Madam Chair.
Thank you. And then Deputy Administrator, is that Ms. McDaniel next to you? Okay, I just wanted to make sure if there was anything else you wanted to add, since this is your wheelhouse when we're talking about maternal and child health.
Great. Thank you. Candace McDaniel for the record. I would say Deputy Peak touched on all of those important issues that we would really feel critical to address and look at. So very much appreciate your time.
Okay, thank you for that, Director. Okay, so unless we have any more questions, with that, I'll entertain a motion on recommendation number 7.
Madam Chair, this is Senator Woodhouse.
Okay, so I have a motion by Senator Woodhouse. Do I have a second?
Second. 1 second. What I wanted to do was read into the record that we move to approve item number 7, including A, B, C, and D, with the provision for the patient to have the right to opt out. That's my motion.
Second. Madam Chair, you're on mute.
Sorry about that. Thank you. So I have a motion from Senator Woodhouse to amend and do pass so that the motion includes 7A, B, C, D, and adding a motion, a provision for the patient to opt out of testing. Do I have a second?
I have comment?
Let me get my motion first and we'll.
Madam Chair, I seconded.
I have a second from Vice Chair Ratty and Dr. Titus, please go ahead.
Yeah, thank you, Madam Chair. Unfortunately, I will not be able to support that motion. I just feel we cannot move forward with this. I think it's critical that we address the problem of syphilis in our state, and that it includes prenatal care, it includes neonatal care, and we can't ignore it. However, I cannot accept this legislation or this potential BDR without clarification on mandates for who will pay for this. I feel it's unfair for ERs and hospitals and providers to potentially hold the burden of this without some sort of assurance that will be covered. So unfortunately, I'll not be able to accept it as long as C is still in there.
Thank you. Do I have any other discussion?
Madam Chair,
Please go ahead, Dr. Hardy.
I think it's not soup yet. And so I will not be supporting it, not because we don't need to do something, but I think we need to do it in such a way that it's more pointed to where we're at and what we need to do. I think it's laudable, but it's got so many different things that haven't been resolved in it. I can't support it as it is. And I know that someday in the real thing, we'll have this discussion, but this will hopefully be a red flag that it's got challenges. So I will be voting no.
Okay, do we have any more discussion? Okay, well, as to something not being ready, I think we have different people have different positions on that, but I'm sure that the deputy administrator and Ms. McDaniel will continue to work with the hospitals and anyone else who is interested in preventing the spread of syphilis and these other diseases in Nevada. With that, Ms. Kamasi, if you'll please take roll.
Senator Hardy?
No.
Senator Ratty?
Yes.
Senator Woodhouse?
Yes.
Chair Cohen?
Yes.
Assemblywoman Monk?
Yes.
Assemblywoman Titus?
No.
Okay, with that, number 7 passes. We will move on to number 8, Ms. Kamasi.
Thank you, Madam Chair. Megan Kamlasi for the record. Item number 8 was submitted in response to Assembly Bill 131 of the 2019 legislative session. It was a study continued from the previous interim related to people who provide care at certain facilities, homes, and agencies. The recommendation was submitted by Assemblywoman Cohen in consultation with Margot Chappell and others at the Division of Public and Behavioral Health. And it would propose legislation to require DPBH to adopt regulations regarding mandatory training for unlicensed caregivers who provide care at certain facilities, homes, and agencies that are licensed under Chapter 449 of NRS. The Division of Public and Behavioral Health would be responsible for identifying which facilities are subject to the training, for setting minimum standards of training on topics related to infection control and prevention, as well as other appropriate topics. The DPBH would also review and revise required topics of training periodically to address new or relevant issues that affect health and safety and they would identify nationally recognized evidence-based organizations that provide free or low-cost training modules on required training topics. And then finally, the recommendation would provide the administrator of each facility subject to the regulations would be responsible for ensuring that staff complete required training and that they document the completion of such training. And then the administrators would also develop and implement an infection control plan based on nationally recognized evidence-based guidelines for the facility. The plan would be required to be updated annually and would have to be provided in writing when it's created, and then annually thereafter to facility employees, contractors, and others who regularly provide services on the premises, as well as to residents. And I believe Margot Chappell from DPBH is available for any questions.
Thank you very much. Committee, do we have any questions?
Madam Chair?
Please go ahead.
Thank you, Madam Chair. Can we have a definition of what quote unquote care is? I know in most of these facilities, as I've said many times, I still the long-term care medical director for Southline Medical Center's long-term care. And what are you talking when you say care? What does that and what does that mean?
Ms. Chappell, do you want to?
Yes, good morning. Margot Chappell for the record. Thank you. Care, I'm not sure we have an official definition of care, but I have Letitia Metherill, who's Deputy Bureau Chief, and Paul Schubert, who is Bureau Chief of the Healthcare Quality and Compliance Bureau. But care generally, this is talking about people who work in the non-medical facilities, such as assisted living facilities, or people who might work in a medical facility that are not necessarily a credentialed staff person, but who are an integral part of their care. Generally speaking, this is for some of the community-based living arrangements, some of the non-medical models that have employees that don't necessarily have to have any medical education. Paul or Letitia, would one of you like to jump in here?
And certainly, I'm Paul Schubert with the Bureau of Healthcare Quality and Compliance. If I may, I would just offer that care, depending on the type of facility, care could mean different things. It could be administration of medication to the residents or clients in a facility, or it could be assistance with activities of daily living, or it could be assistance in bathing or assistance in feeding. So it just depends on the activities that are occurring in the facility and the type of services that that particular facility is offering.
Thank you for that. And so would you perhaps, would there be a stratification based on what type of care they're giving, on how many hours of training you're going to require? So I would guess that somebody's administering medication already has some sort of licensure, the facility has licensure, et cetera, or their family member. How much levels of training, how many hours will be required? Who's going to decide all of that based on what they do? If a certified nurse's aide goes through a certain training, we already know what that requires. So I'm just concerned, have you looked at a model? Are other states doing this and the hours of training that are required based on the level of care, and is that defined somewhere?
Good morning, Margot Chappell for the record. It may be defined somewhere. We can look at other states. We did not do that in the process of this, and we usually do, but we didn't in this case. I think we would probably, what we were looking at when we were writing this together was a standardized set of training that was needed or would be required in regulation and law versus setting different levels for different people or different roles. As you pointed out, Dr. Titus, the other medical professionals have requirements for training already. And so this would be generally for caregivers. And I think we could entertain, anyway, we can discuss that further. Paul, do you want to add anything?
If I may again, it's Paul Schubert. The only thing I would add is that currently we do stratify the training requirements, again, specific to facilities. And in particular, I'm sorry, it looks like I may have lost things. But anyway, in particular for medication management, there's requirements for residential facilities for groups that are different than the requirements. Well, in other facilities, medication administration is not necessarily allowed. So if you're a personal care attendant service provider, you would not be going into a person's home and administering medication, or your employees would not be going into a person's home and administering medications to them. So again, depending on the type of facility, there are some stratification already within our regulations for training requirements. What we were focusing on when we were discussing this legislation or possible legislation was necessarily infection control issues and ensuring that the training that all, across the board, that all caregivers that are not necessarily licensed, such as physicians, nurses, so on and so forth, but all of those non-licensed caregivers would receive the same type of infection control training. And then, of course, it would be evidence-based and from a nationally recognized organization.
And this is Margaret Chappell again. For the record, I just wanted to invite Letitia Matherell, who's also a registered nurse, to weigh in here too. Thank you. Letitia, are you still on? Are you on mute? All right, she must have gotten disconnected, so I apologize. Thank you.
So I guess I want to bring out an example of a personal caregiver, say, taking care of a family member, because we recognize that that's a reimbursable thing. A family member is taking care of mom at home. Will this then they be required for the infectious disease education? And believe me, I support that. I support that if you're going to give care to somebody, universal infectious disease precautions, some of the stuff that we know is just critical, especially elderly, et cetera. They should be educated on that. And I just wanted to know, again, the stratification, who are you going to require to have this done? How will it be available? Reimbursement for that again. And just want to make sure that we're thoughtful about this process. Models in other states, which Ms. Chappell said, you haven't done. I'm just wondering a little bit more how well this has been thought out. Thank you.
Well, and if I can jump in before the others respond, this, especially the first section, has been vetted and has been thought out. It was based on what was going on in another state, and it was a concern with people who were in facilities providing care and didn't have any training, so they could be helping a resident in and out of the bathtub and not have the proper training and causing an injury because of that. So it certainly isn't the intent to, you previously mentioned the CNAs, and I think that was covered by other answers, but this was never the intent to wrap in everyone in the facility, but those people who haven't had training. And then with that, I will just turn it over to Mr. Schubert and Ms. Chappell if they want to respond to the rest of the question.
Thank you, Chair Cohen. Margot Chappell for the record again. Thank you for that clarification too. I apologize. Have to start my video back up again. Thank you. And also I just wanted to clarify, Dr. Titus, that we would not, this is not for unlicensed caregivers. So if it's a family member taking care of a family member in home and that facility is not licensed, this would not apply to them.
So again, follow up on that. This is only for a licensed facility, not a individual family, those type of things. This legislation will only be mandated for a licensed, someone that is licensed under the state of Nevada.
That is my understanding. Margot Chappell, for the record, that is my understanding.
Madam Chair.
Yes, Dr. Hardy.
So I'm just reading, require NPBH to adopt regulations regarding mandatory training for unlicensed caregivers who provide care in certain facilities, homes, So the first paragraph may be somewhat not as inclusive or too inclusive. Then we're talking about the family caregiver, for instance, is unlicensed and in a home, and maybe we can clarify that. I think the intent is good. I can support it, understanding that we aren't real anxious to require everybody who's giving care in a home to be a licensed person, because if we had that, we don't have enough licensed people to take care of people.
Madam Chair, this is Megan Kamlasi. Can I try to provide some clarification?
Please do.
So if you continue reading that same sentence, Senator Hardy, so regarding mandatory training for unlicensed caregivers who provide care at certain facilities, homes, agencies, or providers licensed under Chapter 449 of NRS. So we're only talking about facilities, homes, agencies, and providers that are licensed under Chapter 449 of NRS. So it's not a home that's unlicensed, but it is anybody who provides care or is unlicensed, an unlicensed caregiver who provides care at these licensed facilities. So only licensed facilities must be subject already to state licensing requirements under HCQC, I think typically within DPBH. So this would just be another piece of training or requirement as a part of their licensure.
Appreciate that.
We brought in Margot Chappell and Paul Schubert and Letitia Methrow.
All right. You want me to make a motion, Madam Chair?
Unless we have any other questions. Okay, seeing none, yes, please make a motion.
Move to approve.
I'll second.
Okay, so I have a motion from Senator Hardy and a second from Dr. Titus. With that, Ms. Kamlasi, please take roll.
Senator Hardy?
Yes.
Senator Reddy?
Yes.
Senator Woodhouse?
Yes.
Chair Cohen?
Yes.
Assemblywoman Monk?
Yes.
Assemblywoman Titus?
Yes.
Thank you.
Thank you. With that, the recommendation has passed, and we will move on to recommendation number 9.
Thank you, Madam Chair. Kamlasi, for the record. Item 9 was submitted by John Packham of the Office of Statewide Initiatives, and he discussed it at the June 17th meeting. This was a proposal that was initially developed by, I think it was an NGA working group related to health workforce data collection, and it would propose legislation to enact the Healthcare Workforce Data Collection, Analysis, and Policy Act to improve available data on the healthcare workforce in Nevada. The data would be used to inform health policy planning and workforce development, including health professional shortage area designations and funding tied to HPSA designations for health professionals and facilities in medically underserved areas of the state. So the proposal would have the director of DHHS establishing and maintaining a database with this data and allowing the department to contract or collaborate with a private or public entity to conduct a variety of data collection activities. Part B would require an applicant for renewal of a license by a board to provide the information prescribed by DHHS to their licensure board, and it would apply to licensees under the Board of Medical Examiners, Board of Osteopathic Medicine, Board of Dental Examiners, Board of Psychological Examiners, Board of Examiners for Social Workers, Marriage and Family Therapists and Clinical Professional Counselors, State Board of Nursing, and the State Board of Pharmacy. It provides that a board shall not approve a subsequent application for renewal of license until the required information is provided. It has Part D provides that the State Board of Health, with input from licensing boards and others, will adopt rules regarding the manner, form, and content of data reporting. And then it provides that at a minimum, the core essential data set must include things like demographics, practice status, education and training, average hours worked, percentage of practice engaged in direct care and other activities, practice plans for the near future, and then any additional data elements identified by the State Board of Health. So then it requires the boards, Part E requires licensing boards to submit the data collected to the Department of Health and Human Services on a regular basis. That must be at least annually, and potentially more frequently as determined by regulation in consultation with the boards. Part F authorizes other licensure boards that aren't required to submit data if they would like to. Part G provides that the board shall keep confidential, personally identifiable data, that only aggregate de-identifiable data may be made public, and that none of the data required to be collected by the State Board of Health that's not typically collected as part of licensure renewal may be used by boards to make decisions regarding licensure renewal. It allows boards to promulgate rules as necessary in order to comply with these requirements. And then Part I creates the healthcare workforce or requires the director of DHHS to create the healthcare workforce advisory group, which shall advise the State Board of Health on the development of regulations related to required data collection, survey methodology, and other issues. And then also the State Board of Health and other stakeholders on the use of the data that's collected, with a requested effective date of July 1st, 2021. And I believe John Packham is available to answer questions, as well as Cody Finney, who is a Deputy Administrator with the Division of Healthcare, Finance, and Policy.
Thank you. Do we have any questions, committee?
I have a question.
Okay, go ahead, Dr. Titus.
Thank you, Madam Chair, and I appreciate your tolerance with my questions. I support this. I mean, I think it's important that we know where we are, that we understand who the providers are, where they are. This COVID crisis is a perfect example of need to establish data and make sure we have adequate providers. It also will help us in the future knowing where we need to emphasize our education and make sure our workforce development plans are adequate. Having said that, however, I have a significant concern over number D and then subsection 6. I just think that is not a reasonable request for any profession, let alone focus on healthcare. I don't know who else, when they apply for a license in the state of Nevada, is required to give the 5-year plan on where you will be in the future. I think many of us sitting in front of the screen right now wouldn't be able to say what we're going to be doing in 5 years, whether it's because you're going to stop and raise a family, whether it's you have a healthcare issue or whatever. I just think that particular one is going a little bit beyond what we need to gather data. Probably wouldn't support that, but curious to see where, if Dr. Peckham is available, could answer what other professions are you gathering that kind of information on?
Yeah, I'm actually John Peckham. Can you guys hear me?
Yes, sorry, go ahead.
I can actually address that. That's typically a question in this type of data collection. That's a very general question that I actually think would be quite relevant for pandemic planning. And that is, it's a garden variety, well vetted we can compare it with other states. Do you plan on retiring in the next 2 to 5 years? Do you plan on continuing to practice in the state of Nevada for the next 2 to 5 years? Most of us don't know what we'll be doing next month, given the pandemic. But again, it's just a very general way of getting a temperature across professions on what they plan to do. I would also say that each one of those data elements, I would argue, are to be determined. For example, race and ethnicity. I would seek consultation from other states that have been doing this for years to see what questions yield the best data, which questions even get answered. That's one that's often skipped on surveys. People don't like to tell you their race and ethnicity. I believe it's very important for the legislature and other policymaking bodies, though, to know whether the workforce looks and reflects the populations they serve, including race and ethnicity.
So just for clarification, thank you for that. Just for clarification then, I want to make sure it's broad enough to say that if you check the box, when I renew my license, practice plans, there'll be unknown, can't tell, up in the air, whatever. It's not going to be a mandate that we have to submit each provider a practice plan, literally in writing my plans for the future, because I just think that's way too invasive. And I just want to make sure it's going to be a very open-ended question. Checkbox. You plan on staying in Nevada for the next 5 years? Sure, check the box. That's an easy question versus my plan for the next 5 years is as follows. And again, I understand the need for information, but want to make sure that these are general questions. And again, just for workforce development, and as you said, emergency crisis, are we going to have people here in 5 years, or is everybody going to retire? So I think that's important, but just want to make sure we're not painting us into a corner of requiring that providers provide a plan for.
And I would add, not to get into the weeds, but most of those questions would give respondents the option to refuse to answer, do not know, not applicable, etc.
So there'll be a checkbox somewhere along the line, unknown or refuse to answer, those kind of things. Like I guess, and no penalty for not doing that. I guess that's the other thing. If you don't provide all that information, will the person be able to still get their license? And so will there be the option?
I would not want any of this to get in the way of one person not getting their licenses as expeditiously as possible.
Madam Chair,
Dr. Hardy, go ahead.
is this anonymous?
Yeah, well, the data would be aggregated. It would be collected by the boards. It would be aggregated and sent to HHS and then made available to the legislature, researchers, Medicaid, the state primary care office for HPSA designation.
So in essence, it's not going to affect the licensure of any one practitioner in any way. The practitioner will still have freedom to go wherever she wants to go, do whatever she wants to do within the confines of legality. And it will not be traceable back to somebody who said, I wanted to do this, but now I'm doing that. And it won't have a negative influence on anything.
Not at all.
Okay, thank you.
Okay, do we have any other questions?
Madam Chair,
Yes, Senator Ratty.
not a question. I just wanted to make a comment that I wanted to thank Dr. Peckham for his persistence on this one. He's been working on some form of this for a while now, and wanted to recognize that there are members of this committee who have pitched in and tried to move this along. We got very close to getting this finished last session, but didn't quite get there. So I'm very excited to see it back, and just want to express my gratitude for the persistence of many who keep trying to get this right, and hopefully we'll get there this session.
Thank you for that. And then Deputy Administrator Finney, do you have anything you'd like to add?
Thank you, Chairwoman Cohen. I just would say that this could be incredibly beneficial both to us at Medicaid and at the primary care office to make sure that we have this additional kind of data to support our efforts and making sure we do have a workforce that's both adequate and reflects our population. And just layer in very briefly to Dr. Hardy's point that many of the states we spoke to during the Governors Association project, this data is separated in the design of the survey, is separated from the rest of the licensure data in a way to address your concerns. So really appreciate the opportunity to share that and the opportunity to help support this great project.
Move to approve.
Okay, so I have a motion from Dr. Hardy. Do I have a second?
Second.
Second, I think that was from Assemblywoman Monk. Any discussion? Okay, seeing now, we'll now take a roll call vote. Ms. Kamlasi, if you please.
Senator Hardy,
Yes.
Senator Ratty,
Yes.
Senator Woodhouse,
Yes.
Chair Cohen,
Yes.
Assemblywoman Monk,
Yes.
Assemblywoman Titus.
Yes.
Okay, number 9 passes. We will move on to number 10. Please go ahead, Ms. Kamlasi.
Thank you, Madam Chair. Megan Kamlasi with the Research Division for the record. Item 9 was submitted by Dr. Capurro, who is the state's chief dental officer. This proposal or similar proposals were presented at the committee's meeting, I think it was in February, which related to oral health. And it may not have been exactly presented in this way. Dr. Capurro was another of the presenters who had identified initial proposals for legislation pre-pandemic and revised those proposals based on the fiscal status of the state to try to move the needle on oral health in a way that is cognizant of what's happened in the last few months. So item number 10 proposes legislation to enhance access to dental care through teledentistry, to establish emergency dental responders, and to revise provisions related to the dental loss ratio. So I'm not going to go through the entire thing because it's extremely lengthy, but each of those 3 pieces are outlined. So you have the first piece related to teledentistry is on page 11, 12, 13, 14, 15, and 16. And if you'll look towards the top of the page on page 16, there are some provisions related to teledentistry and Medicaid. Also towards the bottom of page 16 begins the provisions related to emergency dental responders, which just in case that's a term that you're not familiar with, if you look under A1 at the bottom of page 16, it defines dental responders to mean a dentist, dental hygienist, or dental therapist who is appropriately certified in disaster preparedness, immunizations, and dental humanitarian medical response, consistent with the Society of Disaster Medicine and Public Health, and certified by the National Incident Management System of the Federal Emergency Management Agency, or FEMA. As well as some other organizations. And that person must also hold a permit from the Nevada State Board of Health. So establishing this new type of emergency responder. And then, so that those provisions continue on page 17, page 18. Page 19 establishes a committee on dental emergency management. And then on page 20 begin the provisions related to the dental loss ratio. And I believe Dr. Capurro is available to provide more information or answer any questions.
Okay. Questions?
Madam Chair,
Oh, Dr. Hardy.
I think all of that Megan has said is correct, except we have different page numbers.
Right. Yeah, I was just noticing that. So Ms. Kamala, we go up to number 18.
Sorry, say that again.
We go up to page 18.
Yeah, I definitely have a different document. It's this, yeah, apologize. I have edited my document to add in some pieces of information, and it is not the same as yours. So I apologize for that. I mean, all of the information is the same, and I just went through the wrong page numbers. So I can go through it again, or if you look, there are subheadings that indicate the provisions related to teledentistry, emergency dental responders, and dental loss ratio. And I can go through the page numbers with you in just a second.
Madam Chair, I'd rather make the motion to accept than hear that again.
I think for the sake of record, we have to have the documents match up, but Vice Chair Ratty, are you?
Madam Chair, I did have a comment before we got to a motion, though I appreciate and I'm on board with Doc Hardy's efficient suggestion, though I understand we have what we have to do. So we had public comment and I believe written information that was submitted to the committee, may not be posted yet, but we have it from the dental hygienist asking for 4 changes. One is specifically to add the definitions of dental hygienists and dental therapists as recognized healthcare providers to align NRS with U.S. Department of Labor changes. The second one was in section A3, teledentistry definition, to add 2 additional pathways of teledentistry, including mobile dentistry and remote patient monitoring. The third one was to expand the definition in section A5, the definition of dental home to be broader than just children. And I believe the fourth one was under sections C and D, the mandated continuing education licensure, suggesting that be done by regulation. So those were the 4 recommendations. I would like to suggest that when we do make an emotion that we amend the emotion to include the first 3 recommendations. That would keep the 4th still in statute. It may be wise that we eventually move that to regulation, but really what I'm looking to do here is to get all of it into drafting. I found in working on an oral health bill last session that we do much better when we have the language and can go through it line by line. So I'm just hoping that when we do get to the point of making a motion that we can include those first 3 recommendations from the dental hygienists as I just read them back to you.
Okay, thank you. So Ms. Kamlasi, I just want to make sure we've got a clear record.
Thank you, Madam Chair. Yes, the dental hygienists submitted their written remarks as well. And so we have those laid out in writing in the same format that Senator Ratty just went through them. So if the understanding is that you'll include the first 3 with this BDR and not the one that moves the continuing education requirements to regulation, then that is clear enough.
Thank you. And then also just going back to the original work session document being with the page numbers being off from your statement, I just want to make sure we've got that cleared up.
That's fine. That was just, that's not an issue for drafting.
Okay, thank you. Do I have any other questions?
Yeah, I have a question.
Okay, Dr. Titus.
Thank you. I'm just curious as to will it be mandatory then? And again, I support this legislation. I think it's a great idea. We know that access to dental care in our state is very limited at best, and it does affect overall health of our constituents for sure. So looking under the proposal though, going down to, I think I'm trying to figure this out here, under B. Okay, and I'm sorry, under C, when you talk about licensure, if a dental practitioner doesn't intend to use teledentistry, why are you requiring 2 hours of CME if they never intend to do any of that? It looks to require a dental practitioner to obtain 2 hours of continuing medical education in teledentistry. What if these dentists aren't going to do any teledentistry? Why would you mandate that they get 2 hours?
Dr. Capurro, would you like to respond?
I'm here. Can you hear me?
Yes, please go ahead.
Okay. Hello, this is Dr. Capurro for the record. So to answer that question, the CE requirement was built for all providers as a way to provide baseline information about teledentistry, digital records and recording, and to encourage dental and dental hygiene students to be trained on using this technology. In other states such as Ohio, professionals that wish to use teledentistry are required to apply for a permit. And then as part of the permit and fee requirements are continuing education requirements. So instead of a permit and making it restrictive for people to provide teledentistry, this mechanism allows providers to take a one-time CE course and then be eligible to use teledentistry in the state during any time of their practice.
That it seems like, why does my dentist, who's been practicing as long as I've been practicing medicine, has to now take 2 hours to do this when he may or may not retire in the next 4 years or 5 years? It just seems like to require that they take that to be licensed and require it by 2022 is when they have no intention of doing it, just seems a little bit excessive. Certainly going forward, if somebody needs to be able to do that for future license, but current folks who already have a license now to mandate that they take this 2 hours just seems a little bit excessive to me.
Chair, can I address that additionally?
Please do.
So on that note, it would be the hope of this legislation that teledentistry would be widespread and used by the large dental community team. A provider could have a patient come to their practice that had a teledental visit from another provider, and understanding how that appointment was handled or how to request the records would be something I think would be useful. I think this would be a methodology of practice that would be so widespread that it would need to be common knowledge. I think that was kind of the intent behind making it just a one-time CE requirement.
And I would say, I think it makes sense because if we're going to use the hypothetical of Dr. Titus's dentist who plans to retire in the next few years, what if for her next cleaning, Dr. Titus tells her doctor, you know what? I decided I'm moving to Jarvage and I just don't want to be, it's getting too crowded around where I live. And even though that dentist isn't going to use telemedicine, that dentist should have the knowledge to be able to explain to her, okay, well here's what you can do so that you can use teledentistry after your move. I mean, it's just kind of a modernization of the field. And even if a doctor isn't going to participate in it, the doctor should have that knowledge to be able to impart it upon his or her patients, because there definitely is that modernization occurring. So that's just the way I see it. But
yeah, I'm sorry, but to use that analogy, you'd have to say all accountants have to know how to use QuickBook. I mean, I just think that I'm just anxious that you're mandating, and it doesn't really, it's a standard of care. We're looking at that as a standard of care that everybody does. Is really teledentistry the best standard of care, or still being seen in person? I think what we're trying to do is solve a problem of inadequacy, solving a problem of access to care of dentistry, but not mandating that that's a better standard. And if my dentist mandates that we have to come in, then I think, to me, a higher standard is having somebody actually in real time in your office, whether it's in healthcare, primary care, family practice, whatever. It's still the best standard for me. I would be hesitant to accept that a tele anything is better care than the in-person laying on of the hands, actually seeing a person in the office. So that's where I'm hesitant about mandating that they have this training.
I guess my response would be that whereas laying on hands would be better, tele is better than nothing. And the dentist isn't being asked to get a huge, they're not doing 12 CEs on this. It's a small amount just to kind of have some general understanding. Vice Chair Addy, please go ahead.
Yeah, so I have a question, Dr. Capurro. So first of all, I want to thank Dr. Capurro because as you may recall, it feels like it was forever ago, but we did a very long and complete day on oral health because oral health was determined to be one of our priorities for this committee. And I just know that I want to acknowledge, first of all, that Dr. Capurro has put a tremendous amount of work into building the legislative agenda for us, and then went back and did some significant adjustments given the reality of our financial situation. But I think, Dr. Capurro, you've had the most contact with dental professionals as you are in building these regs. And so I guess my question for you is, do dentists have a concern about that CE, or do they see it as, an introduction to this topic is not a bad thing for all dentists to have, as, being on the sort of leading edge of where dentistry is going. So did dentists raise any concerns with you about this specific provision, or any dental provider type for that matter?
Thank you, Senator Ratty, for the question. I have not had any concern about taking a continuing education course. The concern from the Dental Hygiene Association, as I understand it, was that they did not want to make it restrictive for providers to provide teledentistry in the state. This section has been altered from what it started as. It started closer to the Ohio model, which had a permit that was required, and then continuing education that was more specific. The continuing education that's currently listed is 2 hours, and there are also ways of waiving the requirement. I haven't had any concern from dental practitioners that they would not be able to fulfill the requirements, or that it would be so burdensome that they would find this one-time requirement unmanageable.
Thank you.
Madam Chair.
Senator Hardy.
So the way it reads now, require dental practitioners to obtain 2 hours of continuing education in teledentistry. Could we not accept training while they were in school or immediately afterwards? So for the initial licensure, does it have to be, quote, continual education, or can it just be education?
I would assume that type of thing changes over time, but I would ask Dr. Capurro for your input.
Yeah, thank you so much for the question. Number I under C describes the waiver for dental practitioners, which are dentists, dental hygienists, and dental therapists that have completed a teledentistry course as part of their coursework for graduation. So it can be waived if they completed the course during school.
Thank you.
Thank you for that. Okay, do we have any other questions? Okay, seeing none, I will take, I'm sorry, was there a question? No, okay. I'll take a motion to amend and do pass with the first 3 recommendations from the dental hygienist letter being included. Do I have a motion?
I will move that.
Okay, I have a motion from Senator Woodhouse, and do I have a second?
Second.
I have a second from Vice Chair Ratty. Do we have any discussion? Okay, seeing none, Ms. Kamlasi, can we please have a roll call vote?
Senator Hardy?
Yes.
Senator Ratty?
Yes.
Senator Woodhouse?
Yes.
Chair Cohen?
Yes.
Assemblywoman Monk?
Yes.
Assemblywoman Titus?
Yes.
Great, thank you. And that is number 10 passing. That will move on to agenda item 6, which is public comment. With that, we're going to need 2 minutes to give the live stream enough time to catch up and for members of the public to have a chance to call in. So let's do a 2-minute recess while BPS takes care of that. So with that, we'll be in recess.
Hello, Madam Chair. This is Broadcast and Production Services. The public comment line is open and working. However, there are no callers at this time.
Okay, so with that, we will we'll come back from recess with that. So we were on agenda item number 6, and thanks you BPS for informing us that we don't have anyone waiting for public comment. So with that, we will move to member comments. Members, if anyone has any comments before we adjourn.
Madam Chair, I have a comment.
Okay, please go ahead.
I just wanted to take this minute to thank you as the chair for steering us through a very interesting time in health and public health generally. I was impressed by the organization and the focus from the beginning, and then on carrying through on what we said we were going to do, which is, always nice to see that happen. I think there's really good work here on behavioral health, maternal health, oral health, public health, but I also think you as chair were responsive to emerging requests as they came forward. And certainly we got great information about the pandemic as it was happening. So I just wanted to thank you and commend you on a job well done.
Thank you. I appreciate that. And thank you very much for your assistance, which was very much needed and again, appreciated. And I'll just take this opportunity to thank our staff, as always, just the most amazing people that I don't know that the citizens of Nevada know that the hardworking treasure they have in LCB staff, from BPS to legal, research, everyone, Ms. Kamlasi, Patrick, who was helping out while Ms. Kamlasi was was away. And I don't want to name names because I'm very worried that we're going to forget someone, or that I'm going to forget someone. But thank you. Please understand. We know that that it was very hard on everyone, and I definitely appreciate the committee's hard work and getting this done. We also had to continue some hearings and reschedule, and I know that it's a committee made up of very busy members. So I appreciate that. And I certainly also appreciate all of the state representatives from the different state agencies who participated with us, even though you were very busy helping to take care of our state dealing with COVID. So with that, do we have any other comments? Okay. With that, I will be adjourning the meeting. This is going to conclude our meeting and work for the interim. Just remember that your comments for the public, you can still provide us with your comments and concerns regarding these bills that we're putting forward, and that there will continue to be a discussion of these as the session commences, that you'll probably see these bills change as the session goes forward, and that's the way the process is supposed to work. So with that, I will adjourn. Thank you all.